Okay, in Part 2a of Lecture 17, we're going to be talking about electrolytes. The material that we're going to be covering here is once again from Chapter 26 in Marib. Let's first begin with an overview of electrolytes. We've seen these things before. Electrolyte balance is important for really two major reasons. Number one is it regulates fluid or water balance. Remember that water moves where solute moves or electrolytes move. And the second thing is, as especially we saw in AMP1, the concentrations of individual electrolytes can really affect cellular functions dramatically. So that's one of the reasons why this is such an important topic in terms of normal physiology and health concerns as well. Now, if we look at the sources that we have on this diagram of electrolytes and where they come from, we can see that we accumulate electrolytes from some of the foods that we eat, of course, some of the fluids that we drink, apart from pure water, and then also some of the metabolic reactions that occur in the body. So when we have metabolic reactions in the body happen, sometimes these liberate electrolytes that go into the general circulation. So all of these things basically comprise our electrolyte intake. Now, as far as electrolyte output, we can eliminate electrolytes through the perspiration. This is a hypotonic type solution, as we mentioned earlier, and this contains sodium, urea, some other salts, and this is a way for us to excrete or get rid of some electrolytes. We also get rid of some electrolytes in the feces and also in the urine, as we talked about pretty extensively when we talked about the urinary system. Now, a couple of numbers that I would like you to know as far as electrolytes. First of all, remember that sodium is the major cation in the extracellular fluid compartment. And it's important for you to remember the average concentration of sodium in the plasma is about 140 milliequivalents per liter. As far as potassium, remember this is the major cation in the intracellular fluid compartment. Its concentration in the plasma, and this is important for you to realize, is about 4 milliequivalents per liter. Now, its concentration inside cells is about 130 to 140 or so milliequivalents per liter, but that would be difficult for us to measure. So therefore, it's more important that you know the plasma concentration of potassium, which is on an average about 4 milliequivalents per liter. Okay? So we see that the concentrations of these two ions, sodium and potassium, as we've talked about several times, are kind of flip-flopped. High concentration of sodium outside cells, low concentration of potassium outside cells. Inside cells, it's reversed. Low concentration of sodium, high concentration of potassium. Now let's talk about regulation of osmolarity. Now when we talk about osmolarity, we of course come back to our formula that we talked about earlier when we explained all this. And the major thing that we do when we want to regulate osmolarity is that we regulate water content of the body. And really this is the only way to change osmolarity. Let's go through some examples here and look at what we're talking about. Let's take the case first of water loss. So somehow we've lost water, and what that will do, remember, it will leave behind an increased concentration of salts in the body fluids. So this disturbs homeostasis by increasing the osmolarity. This stimulates the osmoreceptors, and as we talked about before, what this will do is increase ADH release. This will also increase thirst. The thirst, remember, prompts us to gain water from the outside to replace the water losses, and the ADH released decreases urinary water loss, so it's a conservation measure as we talked about before. So the additional water that we pick up from the outside, the water that we conserve, all of these help to dilute the extracellular fluid, bring it back to its normal concentration, and that restores homeostasis. Now we can also have, of course, the opposite situation happen where we have a water gain, and here with water gain, what we're doing, if we go back to this formula, remember, if we increase this on the denominator here, what essentially we do is we decrease the osmolarity. So because we're increasing the water content, we're decreasing the concentration of salts in the extracellular fluid. That's going to inhibit osmoreceptors, and that's going to cause a decrease in ADH release and also a decreased thirst. We certainly don't need to take in more water when we have water gain, nor do we need to secrete ADH to conserve body water because we have plenty of it. And when these things are inhibited, what that does is prompt the body to increase its water loss, and that results in a restoration of homeostasis, and it brings the concentration of salts and solutes back into the normal range in terms of osmolarity. Now let's talk about the other side of the coin. This is about fluid volume regulation, and about sodium concentration. Now, notice the situations that we have here. If we disturb homeostasis and we have a salt and water gain, one of the things you'll realize is that if we gain salt and we gain water at the same time, we're going to be increasing the volume of the blood and all the fluids in the body. And this is going to result in a distension of the tissues in the heart. And if you remember from our discussion with the endocrine system, what that does is it prompts the heart to release atrial natriuretic peptides. Remember, the natriuretic peptides, their job is basically to put sodium in the urine. And because sodium is there, water follows. So natriuretic peptides are things that can get rid of excess sodium and water. And so all of these things basically happen when natriuretic peptides are secreted by the heart. We have a decreased aldosterone secretion, so less uptake of sodium. Decreased ADH release, less uptake of water, and a decreased thirst so that we don't take in additional water into the body. All of these result in both an increase in water loss as well as an increased sodium loss from the body, and this will eventually lower the volume of fluids in the body and restore homeostasis. Now we can also have the opposite case where we have salt and water loss. As you might imagine, this will result in a decreased blood volume and blood pressure. And from what we talked about before, remember that when the blood pressure decreases, one of the main ways we bring it back is through the secretion of renin by the kidneys. This causes that whole renin-angiotensin-aldosterone pathway to kick in. This eventually will result in the production of angiotensin II, the active form of angiotensin. And this will result in an increased aldosterone secretion, increased ADH release, and it will prompt all of these things to occur. Their job basically is to increase the volume of fluids in the body and thereby bringing blood pressure pretty much back to normal so that homeostasis is restored. So basically what we can say is that we regulate the volume of body fluids by regulating the sodium content. Keep in mind, as we saw on the previous slide, that the osmolarity of body fluids is regulated by altering the water content. Okay, whereas volume is regulated by altering the sodium content. Because remember, anytime we alter sodium content, we really do affect water as well, because water always follows salt. A couple of facts here down the bottom. Estrogens are chemically similar to aldosterone, and they basically enhance sodium chloride reabsorption by renal tubules. So certain times of the month, for example, women tend to retain water. And during that time of the menstrual cycle, what's basically happening is when estrogens are being elevated, they work like aldosterone to enhance the reabsorption of sodium chloride, and that prompts water gain and water retention. Glucocorticoids can also do this. So anyone, for example, who's on an extended course of glucocorticoids, one of the effects of that long-term therapy is an increase in water retention. Many times you'll see their face kind of get puffy. And one of the reasons for that is the glucocorticoids are also acting to reabsorb sodium. Now this is a summary table of fluid and electrolyte balance. This is important for you to know. This basically summarizes in tabular form the previous two slides that we talked about in terms of water gain, salt and water gain. And once again, I want to remind you that if we want to change osmolarity, we change water levels. If we want to change volume in the body, we have to change sodium levels. I'll take you through the first set of these just so you know how to work the table here. Let's say that we have a change in osmolarity, and the change in osmolarity that we're going to look at is right here. The initial change is a decrease in water in the body, right? So we're losing water, we're getting dehydrated. And what's going to happen, remember, is when we lose water, we increase the osmolarity. So the sodium concentration increases, we increase the extracellular fluid osmolarity. That, remember, prompts the osmoreceptors to increase thirst and also increase secretion of ADH. ADH is a conservation measure to reduce water output. Thirst is a measure to take water into the body and replace the fluid that has been lost. And ultimately this results in water coming back into the body, water being retained by the body, so an increase in water in the extracellular fluids, and that's going to restore normal conditions. Each of these lines in the table basically takes you through one of these scenarios that we talked about in those previous slides with that circular diagram on it. So this table is important. It's very important that you understand this and that you kind of know how to work through the table and you know how the body responds to both changes in water and changes in sodium in water. Now let's turn our attention to potassium. Potassium loss generally occurs via the urine. So this is the major way that we get rid of potassium. The rate of tubular secretion of potassium varies with a couple of things. First of all, remember that changes in the potassium concentration in the extracellular fluid can actually change concentration of potassium in the body. How is that accomplished? Well, what basically happens is when potassium in the body goes up, aldosterone secretion is enhanced. And if you remember at the kidneys, aldosterone causes a reabsorption of sodium in the distal convoluted tubule. In exchange for those sodium ions that are coming back, we secrete and excrete potassium. So anytime potassium levels go up, aldosterone levels go up. This causes increased reabsorption of sodium, but an excretion of potassium in the urine. Okay, aldosterone levels, self-explanatory, we just talked about that. Changes in pH can also affect potassium levels. The reason for this is that both hydrogen ions and potassium ions are univalently charged, positively charged ions. And it turns out that if concentrations of hydrogen ion go up and pH levels in the body go down, the hydrogen ion basically moves into cells, the potassium ion moves out of cells. And so this actually does affect secretion. Now the other way this affects things is that remember that when we have a drop in pH and we have high levels of hydrogen ion, this can cause more excretion of hydrogen ion from the distal convoluted tubule, less excretion of potassium. So if we have a decrease in pH, an increase in hydrogen ion, we excrete less potassium. Whereas if we have a decrease in hydrogen ion concentration in the body and an increase in pH, we'll excrete more potassium at the distal convoluted tubule. So the upshot is for you to remember that we can exchange, in place of sodium, either hydrogen or potassium ion, depending on what the body is going to need. The final electrolyte we want to talk about is about calcium. The normal calcium concentration in extracellular fluid is about 5 milliequivalents per liter. Just to remind you of something we talked about before, remember we talked about the fact that if we want to figure out the, let's use milliequivalents, the milliequivalents per liter, this is going to be equal to the molarity times the valence of an ion, right? So in this case, we know what the milliequivalents per liter, this is 5 milliequivalents per liter of calcium, and that's going to equal, we don't know what kind of molarity. The valence, if you remember, of calcium is 2. And if we work that out and solve for the x here, or the unknown, that comes out to be 2.5 millimolar, or millimoles per liter of calcium, is equivalent to 5 milliequivalents per liter. The key here is to remember this. Remember that calcium is a divalent ion. In other words, it has +2 charge. So it only takes 1 mole of calcium to make 2 equivalents of calcium. And that's the reason why the normal concentration in the body is considered 5 milliequivalents per liter. The other way of saying this is 2.5 millimoles per liter of calcium. Now let's turn our attention to calcium handling. As you see here, we're looking at a situation where calcium ion concentration in the body decreases. And when there's a decrease, there's a humoral signal sent to the parathyroid glands, and they secrete parathyroid hormone. Hopefully you remember that from the endocrine system lectures. Now, parathyroid hormone, if you remember, acts at 3 sites in the body. The first place it acts is at the intestine. And what this does is cause increased absorption of calcium. And this works, remember, in conjunction with vitamin D. And this helps to return the calcium ion concentration toward normal. The second place it acts is at the bone. What it does is activate osteoclasts to dissolve away the bone, that is, resorb the bone. When that happens, we have an elevation of calcium salts, which eventually go into the blood. And this helps to restore the normal calcium concentration. And the last place, remember that parathyroid hormone acts is at the kidneys. So what this does is it decreases calcium excretion from the body, and it increases secretion of phosphate from the body. Calcium and phosphate largely in the body work in opposite directions. So if we have an increase in calcium concentration in the body, we typically will have a decreased concentration of phosphate. And that's why it says what it says here in this box. But essentially what we're after here is the calcium handling. So when we have parathyroid hormone present, this basically conserves calcium and causes less excretion of calcium in the urine. So these are the 3 ways that calcium handling is affected by parathyroid hormone from the parathyroid glands. And just for review purposes, I set up a table here for you that gives you the concentrations of things. You'll see that really what I want you to know is the first column of this table and the last column of this table. You should know the electrolyte, As before, I mentioned that you should know the chemical symbol as well as the valence of these ions, and you should also know the typical values that you see in the third column here. These are the average values that we have. And of course, there's always ranges of things, right? Like we might see in laboratory tests when it gives you the range of normal values. But for our purposes right here, just so you have an idea about the concentrations of the different ions, it's important for you to know the average concentrations of these. Okay, so that finishes off Part 2a of Lecture 17. I'll see you very soon for Part 2b.